If you are in Delhi, I hope everyone is safe and their families are safe. We'd like to take you through a project that we did from December 18 to somewhere around November 2019. So before we begin, I would just like to add that we just had our merger with Pfizer on the 16th of November. That is why we are now called Viatris. So we are not Mylan anymore. We are Viatris. Just a little.
How do you spell? How do you spell this?
Viatris. It's there on the presentation, sir.
Okay.
Okay. So I would like, without further ado, I would like to begin with my presentation. We call it the multi-pronged strategies in TB interventions. So a little background about tuberculosis is that tuberculosis is a big burden globally as a disease. And if we talk about India, it has 1/4 of the global burden. So the entire burden divides into 4. 1/4 of that part is on India. And of the total burden that India has, the 20% of that burden is in Uttar Pradesh. So hence we thought of doing our project in one of those districts of Uttar Pradesh. This is an aspirational district project which is done by Niti Aayog. Bahraich is one of the aspirational districts project of the Niti Aayog. So to understand, TB usually has 2.2 million notifications a year in India. But to understand that this is not enough. However, we absolutely appreciate what the government is currently doing to eliminate tuberculosis. Hence, we echoed the thought with the Honorable Prime Minister, who said wishes to eliminate tuberculosis out of India by 2025. Hence, we echoed our thoughts with them and we proposed a program to the Niti Aayog, to the National Elimination of Tuberculosis Program. So I will take you
through. Your presentation is not moving on the screen. Is this?
I will take you ahead, sir.
Okay.
So, are you able to see it now, sir?
Now I can see.
Yeah. So TB, as I explained, that TB is a huge challenge for Indian government. So the Prime Minister wishes to eliminate tuberculosis by 2025. We wanted to echo our thoughts with that, and hence we picked up an aspirational district called Bahraich in Uttar Pradesh, and through our CSR initiative, we did the following things, which will be presented to you in the slides to come. So the objectives of the program were divided into 3. The active case findings. We went door to door with a questionnaire to the households, explained them about tuberculosis, evaluated them on the basis of the questions, and found out high risk individuals. Then how did we do further to the high risk individuals? We'll come later on. The second objective was public health, public awareness and education around tuberculosis, as we all can agree that tuberculosis is a taboo. There's a lot of stigma around that is attached to tuberculosis. Hence, we aimed at sensitizing the general public, the healthcare practitioners, that TB is curable. TB is curable, and hence we did IEC materials, the activities, so that the general public does not alienate a TB positive case. There is now the third objective was there is already a workforce by the government in these districts. We made sure that we do our bit by capacity building and educating them on tuberculosis as well. How is tuberculosis managed if a positive patient comes? So to put it in brief, there were 3 objectives: active case findings, public awareness, and capacity building. So the rationale of the project revolved around that we wanted to identify high-risk individuals, we wanted to screen them for tuberculosis, and we wanted to link them to care. We just did not leave them by saying that this is a positive case. We did not give it to the government. We linked the proper channels of the government and made sure that the TB positive patient, TB positive individual receives medication. And hence we did that project. Now the methodology and the interventions that we could do. there was a micro planning that was required at the volunteer level. They had to be sensitized, they had to be oriented and explained how is a high risk questionnaire run, what are the questions that they ask, how do you go door to door, how is the high risk questionnaire is to be implemented. Then, on the basis of certain questions that were asked, as if, for example, if you have been coughing for a week, if you have fever, if there is blood in your sputum, so this made them a high risk individual. We categorized patients into high risk category. We collected their sputum, and of course, Bahraich is a district on the outers of Uttar Pradesh, where obviously transportation was a challenge. So we linked the collection of sputum to transportation, taking them to the designated microscopy centers, testing them. If they are positive, then again linking them to the care. 100% patients, 100% family was screened. For example, if a patient was positive, their entire family was screened. Their students were tested. And with, I say this with utmost proud that we did not leave a single stone unturned. We linked everyone, each and every positive case to care. We made sure that their treatment is initialized and they receive medication. So so if we were to analyze the project, what were the achievements of the project? So the outcome of the project was we screened nearly 1.2 million population of Bahraich and distributed them in 5 blocks. Out of these 12 lakh population, these entire 12 lakh population was run through a questionnaire. On the basis of questionnaire, 6,070 individuals were identified as high risk individuals. They were tested, out of which 617 tested out to be positive for naive TB. Then there is a further aggravated disease which is known as multi-drug resistant tuberculosis, which is MDR-TB, that were 77. And there were healthcare practitioners who were practicing privately and looking and seeing patients of tuberculosis outside the government infrastructure. So there is a mandate in the public health that if a private practitioner is seeing a patient, he has to notify a positive patient to the government. And we made sure in that 1 year that happened. We sensitized the healthcare practitioners. The new notifications from private sector itself stood at 253. So nearly more than 700 new cases were brought into the government infrastructure. They were started on treatment. And I think we managed it by there's a managing the entire channels in the linking. So to talk about the impact, I think it is very important. The impact that our presentation, the impact that the presentation that the project had, that nearly more than 12 lakh people were screened, 6,070 were put on board, they were linked to care, and I think we made a difference. We, and I say this with again, I say this with a lot of humility that we as a company do not see healthcare as it is. We see healthcare as it should be. So talking of which, Bahraich project really is a feather in the cap that we did, and Niti, and this goes without saying that it was only with the support of Niti Aayog, Central TB Division, and National Tuberculosis Elimination Program. So, so these are the pictures that were taken on ground. This is the on ground report. You can see how are these volunteers doing questionnaires, screening them, telling them about tuberculosis, how is a sputum collected. All these sputums were collected in the morning so that these are daily wage earners. So if we give them a task or a government gives them a task to go and get yourself tested, they lose a day's wage. And we did not want that to happen. We want their families to function smoothly, irrespective of the fact that they have or they do not have tuberculosis. So we made sure that the sputums are collected in the morning. Only the samples go for testing. The individuals can carry on their day routine as they are. So with all of this said, this project is very close to us, and we believe that it did create an impact in the UP government, in the central, in the national program of tuberculosis, and and this was just a pilot. We eventually planning to do it further. So if we were talk about the scalability of the project, ACF active case findings are already being done by government, but not everywhere. We just want to catalyze the project, to catalyze the process. The government does it in XYZ district, we do in ABC district, so that the entire population of these aspirational district project of the Niti Aayog can be screened, and actually data can be brought on board, and we can understand how tuberculosis is troubling the infrastructure. With that said, I would like, I hope I didn't exceed the time. I would like to thank everyone, Niti Aayog, CTD, Mylan CS, Beatrice CSR, and with the hope that we made a difference and we continue to do so. Thank you.
Yeah, it's wonderful presentation, and it's very. Thank you for completing very much in time. Am I audible?
Yes, sir. Absolutely audible, sir. Absolutely audible.
Okay. No, you have taken a very challenging task, although at the modest level.
Thank you.
The aspirational list of categories is just an example, but it sets rather an example for the rest of the country in one way or the other.
Thank you.
And one of the things which makes me curious, maybe you may throw light on this. Yes, what are the causes traditionally that is responsible of incidence of TB, and what are the other new emerging causes that contribute to incidence of TBs? Number two is that another. I mean, this is your work. I'm not telling you. You're doing perfectly all right. As you said, 1/4 of the India's population is affected one way or the other by the TB, and the magnitude is good. Now, what would be the, our strategy, considering that almost all the districts have varied magnitude, but its presence is pan-Indian. Yeah. So how do we address to this larger issue, taking a call from your understanding and the survey you made and the approach you had by linking to the TB affected person to the various agencies and so on. So kindly reflect.
Thank you. And I would like to say before I answer the question, this is coming, I'm sure you already know tuberculosis, because this can only come from someone who already has seen TB. I mean, who knows how TB is in the Indian infrastructure, in the Indian country. So, sir, to answer your question, I'll start with the first question. What are the reasons of the emerging tuberculosis in Bahraich? So the basic reason that we saw was the lack of knowledge. The lack of knowledge that revolved around tuberculosis. People went coughing for 14 days and they did not know they have TB. And hence, they went on spreading it. This is one. The second is the poor sanitation. The poor sanitation that revolves lowly ventilated houses. Of course, smoking. Of course, the smoking of BD, as we say, is one of the prominent reasons that was the reason of emergence of tuberculosis in Bahraich and Uttar Pradesh on the larger level. So this is how they get infected on. So one is when someone is infected, it keeps on spreading. So if I don't know I have tuberculosis, without knowing, I'll be spreading it to hundreds of people. This was the one reason that I wanted to state first, because it was the poor lack of knowledge around tuberculosis. Now, so coming to your second question, that just I stand myself corrected that not the 1/4 of population of India is infected. What I meant was that of the total burden of tuberculosis in the world, 1/4 of that burden is in India.
So its magnitude even higher.
Yes, sir. So it is even higher. So, sir, talking about strategizing how tuberculosis can be eliminated. So I'm sure you will agree with me that it is deep rooted. So if it is in a district of Bahraich, which is on the corner, on the borders of Nepal in India, then this means this disease is deep rooted. And hence, when we need to eradicate something this deep rooted, there has to be micro planning. We need to think a level way below than at what we are sitting on. For example, we have to reach to door. Of course, it is, having said that, the population is humongous in India, but this is how we can eliminate tuberculosis, if at all we wish. Of course, we wish to. Reaching door to door, knowing if, so for, I would like to state an example of a village called Idukki in Kerala. How did that Idukki village is a TB free village? This does not mean that they do not have cases of tuberculosis. They have cases of tuberculosis, but they know that the cases in Kerala of Idukki village of Kerala, are in this house, X house. This has 2 number of patients, that has 4 number of patients. So if we know the total number of cases in India, we have eradicated TB. The problem is that we don't know. This is just the data that I'm sharing, that is published data. Of course, the magnitude is even higher than that. And we do not know how deep rooted is it. So with all that said, this has to be micro planned. Door to door survey which is not viable right now. But to eradicate tuberculosis,
should this
we
be,
have to hit and knock each and every door.
In that case, should this be an important component of Ayushman Bharat, where they take care of around 50 crore people and 10 crore families, and mostly BPL and APL. So the entire, I mean, I understand as for the given situation of TB as it emerges from the living conditions and the lack of knowledge of the spreading of and contagiousness and the other factors. But should we start from Ayushman Bharat, especially from the BPL families which are identified, as an effective first step towards, in a phased way, to cover all these people through scanning?
I think you said it, sir. You absolutely nailed the nail. So, the reach to 50,000 families is a task already. And if the government has reached to them, of course, they can screen it and they would have a fair idea of tuberculosis. Yes, I agree.
Thank you.
Thank you, sir.
Excellent starting.
Thank you, sir. Thank you so much.
I was just trying to look at,
Good afternoon, sir.
as why did you do what you did? Actually, what you wanted to showcase, I am not very clear.
Yeah.
You did Bahraich, fine. You did house to house survey and all that. But what is that which you wanted to showcase, and what is that which you have achieved? What are the learnings from this survey? So if you can just briefly tell us in 2-3 minutes.
Yes, sir. So what we wanted to achieve was that, so just to throw some light, that an aspirational district, I'm sure people in the jury already know, I would just like to, for the record, I would like to say it, that these are poor performing districts in one or the other parameter marked by the government of India. These are 100 districts which are chosen by Niti Aayog. Bahraich was one of them. We wanted to do this. We wanted to show an impact in this district was because, so as I said in my initial statements, that of the total burden in India, TB burden in India, UP has 20% of that, and the type of notifications that we want to achieve, that the government wants to achieve, are way below, and hence we wanted to do a pilot and just put it across that if this is done this way, for example, if we do a door-to-door questionnaire survey, if we evaluate the risk, if we link them to care, this is what can be achieved from one district.
No, have you shared your findings with the Niti also?
Yes, sir. Yes,
Yeah,
So
they
one
have
or
shared.
two major findings. One you have told is that house to house survey is required.
yes, sir.
What
Yes, sir.
else?
House to house survey is required. Education around tuberculosis is very important. So this was the second. This was the one of the objectives of the project, that we wanted to educate the population of any district that we pick up, that tuberculosis is not a taboo. It is not a stigma. There is a lot of stigma that is attached to tuberculosis, and not only just households. We wanted to educate the volunteers on how TB is to be managed. Why is adherence to treatment required? If a person does not adhere to a treatment, to his or her treatment, there's a chance that the disease aggravates. From naive TB, he moves to MDR TB. From MDR TB, he moves to pre-XDR TB. The situation gets worse. So early intervention was required. That is why knowing initially that he had TB was important. This was also one of the objectives of the project, that early detection. And hence we shared a report with the Central TB Division and Niti Aayog, sir. This is what we wanted to achieve.
Okay, thank you.
Thank you, sir.
Dr. Datta, just one half a minute. See, I mean, since this is a subject of knowing
Yes, sir.
and general awareness, should we consider that such kind of critical areas should be also disseminated through curriculum of school and everything, that the children from the learning process are made aware of, so that will have an impact?
Absolutely. You said it, sir. So because train them young, example is what train them young is a old statement that has been coming. If I am a 30-year-old individual, I have been unaware of TB for 30 years of my life, and suddenly you come and tell me that this is the important disease you need to be aware of. It is going to hit me as a shock. But yes, if we educate kids in primary levels, secondary levels, they will be aware of TB as a disease, what are the preventions, and if someone in their family, their close relatives, their areas, their localities has TB, they will not be traumatized. And sir, to add to that, this is being done in some part of the state of the country. Tuberculosis is a part of the curriculum. You're right.
Good. Thank you.
Thank you, sir.
Thank you very much. Excellent.
Thank you, sir. Thank you for your time. Thank you for your patience. We look forward to hear from you.
Thank you, sir, for your presentation. Now, next presentation is from a District Rural Development Agency, Kudalur. Their project name is Kudi
Yes, Kudashi.
Meramathu. It's over to you, sir.
Yes, sir.
From Kudalur. You can start your presentation. Thank you.
Good afternoon, sir. This is Chandrasekhar